Welcome everyone to EAUTV. I'm Claudia Kesch, a urologist from Essen, and we are back with the Game Changers. Today I'm with the lead investigators of the NeuroSAFE PROOF trial. Welcome, thank you for being here. And maybe can you introduce yourself first?
Sure. So my name's Professor Greg Shaw. I'm a urologist from University College London, and I'm chief investigator for this study.
Hello, my name's Eoin. I'm also from London. I'm currently working in Melbourne, Australia at the Peter MacCallum Cancer Centre, but my involvement in the NeuroSAFE PROOF study was as a PhD student through 3 years from 2018 to 2021, and then through till presentation today at EAU in Madrid.
Wonderful.
Yeah, and I'm Ricardo Almeida. I'm also a clinical research fellow like Eoin, and I basically did the work after him to carry on with the study, and we work together to publish and finalize the study.
Perfect, thank you for being here. So to start, can you give us a small introduction to the trial and let us know a little bit the study design?
Yes, so most people will be familiar with the NeuroSAFE technique. It's an intraoperative margin evaluation which allows the surgeon to do a secondary resection if the margins are significantly positive, to optimize the opportunity to spare nerves and decrease the risk of detrimental cancer control due to nerve sparing. We ran a randomized controlled trial which as a primary endpoint we looked at the potency of our men 1 year after surgery using the IIEF5 patient reported outcome measure. And we performed this study over 7 years and recruited at 5 UK NHS centres.
Thank you. So at EAU you presented the first results, and simultaneously a publication came out in Lancet Oncology. Can you briefly summarize the main findings for us?
Correct, thank you. So 190 men in the NeuroSAFE radical prostatectomy, the intervention group of the study, 191 men in the standard radical prostatectomy group. All men in the study had a preoperative personalised nerve-sparing plan produced by a blinded radiology consultant in the UK and using their PSA and their biopsy information. And then they went forward to have their prostatectomy as per random allocation to their respective groups. We know that the NeuroSAFE technique puts an extra 43 minutes on the length of an operation, but we also know that we dramatically increased the amount of nerve sparing in the intervention arm or the NeuroSAFE arm. So for bilateral nerve spare, in the standard arm, 50% of men received the bilateral nerve spare, and in the intervention NeuroSAFE arm, 83% of men received bilateral nerve sparing. If we fast forward through to the primary outcome measure, which is the erectile function recovery at 12 months, we see a 3.18 adjusted mean difference in favour of the NeuroSAFE radical prostatectomy. And that is overwhelmingly statistically significant as well, with a p-value of under 0.001.
Thank you. And let's also talk a little bit about the oncological outcomes. There were slightly more patients with PSA persistence or biochemical recurrence in the intervention arm, and I would be interested, was that a statistically significant difference, and did you follow up on these patients? Do you have any imaging information if these were all local recurrences?
Yeah, thank you for the question. I think that's one of the big questions. We know it helps patients, and one of the things that I would like to highlight for the study is that we achieved a very high completeness of data. So for oncological outcomes, actually was the one that was highest. We were not powered to detect a difference in oncological outcomes. We didn't test for it, but there doesn't seem to be an important difference between the groups. It's just a minor numerical difference. I don't think it's clinically relevant, but as we acknowledge the importance of that outcome, we'll have long-term follow-up. So right now we're finalizing the 2 years follow-up, and we'll follow patients for 5 years. So we expect to publish on that.
Okay, we wait and see a little bit. We just talked about the significant higher EAF at 12 months in the intervention arm. I'm wondering, like, does this significance also translate to a clinically relevant significance?
Thank you for the question. I love the question because I think it's really important for patients. I don't think patients will look at a 3.18 adjusted mean difference and say, oh great, it means it. But so if we look at some of our exploratory descriptive outcomes, and your audience will be able to see a really nice histogram in the Lancet Oncology published paper, we see that if you categorize men at 12 months, according to the severity of erectile dysfunction or erectile function recovery, let's say, and if you look at no erectile dysfunction or very mild erectile dysfunction, we almost double the amount of men achieving that optimal outcome at 12 months following surgery in the intervention arm compared to the control arm. An 18% increase in the number of men achieving either no erectile dysfunction or mild. And I think patients will understand that. I think urologists can understand that. And I think it speaks to the strength of this technique in the men in whom it will benefit.
Okay. Another important issue obviously is OR time and costs. Do you want to comment a little bit on that?
Yeah, absolutely. So we acknowledge it's a time-consuming intervention. We had to basically in the study where we did the most of the cases, the histopathology department is actually far away from the main hospital, so we have to transport samples. That adds to the time that the patient is under anesthesia. We didn't see a difference in outcomes relating to that delay, but we acknowledge it increases costs, and we believe that the balance between the benefits like let's say that even if you take into account that cost, the benefit that gives to the patients by far outweighs the risks.
Thank you so much, and thank you for presenting the trial here. So one last question for all of you. Based on your results, would you say that NeuroSAFE should become the new standard of care?
So I think our paper demonstrates clearly that there is a marked benefit for men who are potent with the NeuroSAFE technique. We performed a sub-analysis, a predefined sub-analysis, which shows that the benefit is even greater in those men who wouldn't otherwise be offered a bilateral nerve-sparing operation. So acknowledging that this is quite resource intensive, it takes a lot of work to set up. If centres are able to do it, I think it should be offered to men who are potent and who are not otherwise going to get a bilateral nerve spare procedure. But we do acknowledge that it may be difficult for some centres to set this up. And what's key here, I think, is that an evaluation of the margin status intraoperatively is important, and there are new technologies coming through which are likely to democratise that, make it more available in other centres who perhaps can't do NeuroSAFE.
Yes, perfect. Well, thank you so much. Thank you for being here.
It's a pleasure. It's a pleasure.